Good morning, everybody. So today I'll be taking my presentation of MDR gram-negative pathogen. I'll be discussing about the detection methods, treatment of modalities, and the future options. So I'll be dividing my presentation into various headings. These are problem statement. I'll be discussing about the classification of carbapenemase, then how do we screen and how do we confirm the presence of carbapenemase enzyme, then what are the various treatment options available. Then I'll be discussing briefly about the individual drugs, then what holds for us in the future, then how do we prevent the spread of MDR pathogen in our setup, and finally about the oil-based data. Now this slide shows the basically CDC, what CDC said in they had their antimicrobial resistance statement. So they have quoted WHO saying that 3 out of 4 pathogen designed as being critical priority for research and development of new antibiotic are carbapenem resistance pathogen, including carbapenem resistant enterobacteriaceae, carbapenem resistant pseudomonas, and Acinetobacter carbapenem resistant. This is what the WHO said in 2017, and based on that, CDC has given a list of threat. They have made a threat report, and urgent threats are include those organisms which require immediate attention, and these include, as we can see, include Acinetobacter baumannii, which is carbapenem resistant, and also carbapenem resistant enterobacteriaceae, which include E. coli, Klebsiella predominantly. So that means majority of the pathogen, now we are at that state that they become the last line of management is carbapenem, and also we are encountering a lot of resistance to these last line resort as well. Now our data is no more different. As we can say, as we can see here in the slide clearly, so here we have 2019 and 20. 19 you can see in blue bars, and this 20 you can see in red bars. So this is a percentage sensitivity. So as you can say, we are at the end of the tunnel. So BL-BLI combination, all the cephalosporin, so all the fluoroquinolones, all the aminoglycosides, all the carbapenems are becoming resistant. So with the sole exception of colistin, which is not a very good drug to use. And based on this, we have started in 2020, we started the sensitivity testing for other organisms like other antibiotic like ceftazidime, avibactam, then ceftazidime, sulbactam, EDT, and phosphomycin. So they are still retaining some sensitivity, but the way we are going now, so soon will be out of our armory totally. So although the Klebsiella is MDR, but a slight better perspective is in case of E. coli. The E. coli sensitivity is still preserved to various cephalosporins and carbapenems, and also to aminoglycosides. That is why we are not testing all our E. coli against ceftazidime, avibactam, as we are doing for Klebsiella. But for E. coli, we are not doing it because we want to preserve this drug for future. So now, as we have seen that most of the organism belonging to Enterobacteriaceae family, they are resistant to carbapenem. Now let us focus our discussion on resistance mechanisms to carbapenem. Now, MDR GNB, basically most of them are resistant to carbapenem because of their ability to produce an enzyme called as carbapenemase. And it's as you can see, it's a carbapenem hydrolyzing beta-lactamase. So that give resistance to broad spectrum antibiotic, including ranging from beta-lactam substrate, including carbapenem. And although the carbapenem resistance is predominantly because of carbapenemase enzyme, but there are various other mechanisms are also documented which can confer resistance to carbapenem, which include upgradation of efflux pump, and also the porin modulation. So they also impart resistance to carbapenem in Enterobacteriaceae. Although the most important factor which impart resistance to carbapenem is the production of enzyme carbapenemase, and most of the strains which harbor carbapenemase enzyme, so they are also resistant to other drugs, especially fluoroquinolones and aminoglycoside group of antibiotic. Now let us just briefly spend some time on this slide. So this slide demonstrates the classification of beta-lactamase. So this is Ambler classification. So we can classify carbapenemase or beta-lactamase in two categories. So one is serine beta-lactamase and second is metallo-beta-lactamase. So serine beta-lactamase are those which require serine moiety at the position 70 for the activity, and metallo-beta-lactamase are those enzymes which require zinc ion for their action. Now, serine beta-lactamase can be further classified into class A, class B, and class D. Now, members of class C predominantly include those beta-lactamase which impart resistance to cephalosporins. That means class C include majorly cephalosporinase. A lot of them are there, but the most predominant one is AMP-C. So remember, AMP-C is a class C beta-lactamase which impart resistance to cephalosporins and not the carbapenem. So carbapenem resistance is basically mediated by Ambler class A, class D, and class B respectively. Now, class A include lot of beta-lactamase. Some are called as narrow spectrum beta-lactamase, which impart resistance to first and second generation. Then which include SHV and TM predominantly. Then we have extended spectrum beta-lactamase, which include again SHV2 and CTXM, very important CTXM. And then the third, which is the most dangerous one, is the serine carbapenemase. So these carbapenemase, they include KPC, IMI, and SME1. So these are the one which are more worrisome because they will impart the resistance to carbapenem as well. And class D carbapenemase include basically oxa type. The name oxa is because they are predominant affinity for oxacillin as compared to penicillin. And these oxa type are predominantly produced by the Acinetobacter bacteria, but also now they are being produced by Klebsiella pneumoniae E. coli. So most of the oxa, they belong to Acinetobacter like oxa 11, oxa 15, 23, and 48. Then we have third category of carbapenemase called as metallo-beta-lactamase, which are called as class B carbapenemase. So they require zinc moiety for their activity, and that is why they can be inhibited by the chelating agent like EDTA, which include Vim, IMP, and NDM. NDM we all know is a notorious one, first isolated in New Delhi. So now coming to detailed classification, now the class A beta-lactamase with carbapenemase activity. So now genes for these resistance gene can be coded on chromosome and plasmid. Now we are not very worrisome about the chromosomally encoded genes because they are not transferred horizontally. So that is why the resistance is not that common, which include serine, serratia marcescens enzyme, then non-metalloenzyme carbapenemase, and imipenem hydrolyzed beta-lactamase, said as SME, NMC, and IMA respectively. But here we are, the more worrisome group is plasmid encoded, the resistance gene. This includes most commonly KPC. Now KPC is a big problem in developed countries, especially in Americas, in Europe. So there are multiple type of KPC 2 to 22, and all are predominant worldwide globally. Then we have new one called as GES, which is also extended spectrum lactamase, which impart resistance to carbapenem as well. Now, as you can see further, so as we have discussed already that SEM, IMI, so as they are chromosomally encoded, so they are typically found in one species of bacteria like Serratia marcescens. IMI is typically present in Enterobacter. NMC is present in Enterobacter. So the other one, that is GES and KPC, as you can see, they are not limited to one genus. They are present in multiple genuses because of their horizontal transmission, which include mainly Klebsiella pneumoniae and Pseudomonas aeruginosa. Out of this, KPC is most important because, as we have discussed, the plasmid encoded, and this can be transmitted easily to other bacteria like E. coli, Pseudomonas, Citrobacter, Salmonella, Serratia, and Enterobacter species. And one of the new one is BKC1. This is also plasmid encoded. This is now isolated in Brazil, and now it is spreading fast worldwide. Now, second is we have class B beta-lactamase. So as I've already told you that they are called a metallo-beta-lactamase because they require the zinc moiety for the activity, and therefore they can be inhibited by a chelating agent like EDTA. So now again, class B beta-lactamase resistance gene can be either chromosomally encoded or it can be acquired. The chromosomally encoded resistance is intrinsic resistance, which is present only in few selected species like Aeromonas, Chrysobacterium, and Stenotrophonas, whereas the acquired one, which is mainly plasmid encoded, is basically responsible for hospital outbreak, and genes responsible for acquired resistance, they are present on introns, which are present on the large plasmid between species and various genera, and they have a potential of causing hospital outbreak. And the important ambient include IMP, VIM, GIM, SPM, and SIN. Now of these, the most important one, notorious one, which has gained importance, is NDM. So NDM was first isolated in a Swedish patient who come for the treatment in India in December 2009. And now why it is so important? Because the genes which are coding for this MBL, so they are present on highly mobile genetic element, maybe on transposon. So they have an unpredictable pattern of spread, and it is spreading very fast. And most importantly, the genes which are encoding for MCM, NDM, so they are also gain resistance to colistin and tigecycline very fast. So although they are initially susceptible, but once they are positive for NDM, we know that in near future they will develop resistance to tigecycline and colistin very fast, and they're predominantly present in members of Enterobacteriaceae family, including E. coli, Klebsiella, Enterobacter, and also in some Acinetobacter species. Now coming to the third category of carbapenemase, is called as class D beta-lactamase, which is also called as oxa type. So now it is called as oxa type because they have more potent in hydrolyzing oxacillin as compared to penicillin. There are many subgroups of oxa type carbapenemase. Of this, majority of them are present in Acinetobacter baumannii. The 6 one are the predominant: oxa 23, 24, 48, 58, 143, and 51. So with the exception of 51, which is chromosomally encoded, rest all are plasmid encoded. That means 23, 24, 40, 48, and 58. They are all plasmid encoded, and hence they have a potential to spread very fast. And of these, oxa 23, 24, 40, and 58. That means these one, they are predominantly produced by Pseudomonas by Acinetobacter. However, oxa 48, which is having a problem in our setup, so this is produced by Enterobacteriaceae family. So Acinetobacter does not produce oxa 48. So oxa 48 is produced mainly by the member of Enterobacteriaceae family, and it has shown some variable susceptibility to carbapenem. So thankfully, it retains some susceptibility to carbapenem, whereas the oxa which is produced by Acinetobacter baumannii, which include 23, 24, they are invariably resistant to all the carbapenem available. But the oxa 48, it retains variable susceptibility to carbapenems which are available. And obviously, they are metallo-beta-lactamase, so their effect is variably affected by beta-lactamase inhibitor. They are not affected by BLIs like clavulanic, sulbactam, and tazobactam. So now there are some additional issues, as already I've emphasized, that in addition to resistance to penicillin, cephalosporins, and carbapenem, so the organisms which are harboring these carbapenemase enzyme, they are also resistant to other antibiotics, especially aminoglycoside and fluoroquinolones. In various studies, it has been observed that the Klebsiella pneumoniae carbapenemase, that is KPC, which is serine carbapenemase, class A carbapenemase, so which is carrying in Klebsiella pneumoniae. So these which are having these Klebsiella pneumoniae which are harboring KPC gene, so 98% of them are resistant to fluoroquinolones. That means almost all of them are simultaneously resistant to fluoroquinolones, and half of them are resistant to aminoglycoside like gentamicin and amikacin. So that is again a problem with us. Now, what are the risk factors which are there? Which basically make a person prone to infection with this carbapenemase producing enterobacterials? So use of broad spectrum antibacterial is the single most important risk factor, or previous use of carbapenem is a risk factor for developing colonization of infection. So various studies, you can see in this study, it has been concluded that exposure to antibiotic within 3 months was an independent predictor that characterized the patient with CRE isolation. As a result, antimicrobial stewardship effort is a major focus to prevent the infection. So previous exposure to any of the cephalosporins or carbapenem, that is a very important risk factor for developing, for having the CRE enzyme or carbapenem resistant enterobacterials. So although this is a major risk factor, other risk factors include trauma, diabetes, malignancy, and the lower ones are very common in our setup: organ transplant, mechanical ventilation, indwelling catheter, or severe illness. All of them, they predispose the person to infection with the PD or GNB because of their prior exposure to any kind of antimicrobial agent. Now, what happens now? What are the steps in the lab that we take? Now, first of all, whenever we receive isolate, we get isolate, especially E. coli and Klebsiella. First, we check their susceptibility to carbapenem. So, if the susceptibility to two important carbapenem, that is imipenem and meropenem, is basically below the breakpoint, MSC is below the breakpoint as given by Clinical and Laboratory Research Institute. So, if it is below that, it is susceptible. If it is above that, then probably it is resistant. And resistance is probably because of the production of enzyme carbapenemase. And if we suspect the production of enzyme resistance because of carbapenemase, we can further do some phenotypic testing, and as well as molecular testing can be done to detect the specific genes which are responsible for carbapenem resistance. So first we do screening. As I said, we look for MIC for imipenem and meropenem. As per CLSI, any isolate having MIC of less than 1 is considered sensitive, more than 4 is considered resistant. So anything which is coming above 4, then our suspicion is raised. It is obviously resistant to carbapenem, but we suspicion is raised that whether it is because of carbapenemase production or because of some other mechanism like porine overproduction or efflux mechanism. So for that, we can do some phenotypic methods and genotypic method. So phenotypic method include double disc synergy test and EDTA, MBL test, carbapenem inactivation test. This can be done easily in the lab, or more commonly these days we are doing genotypic detection, which can detect the resistance gene, because phenotypic method can miss some of the genes, obviously, because some genes are not expressed at all the time. So we can miss some of the genes by doing phenotypic methods. Genotypic methods are more confirmatory. We can do multiplex PCR assays, and DNA marker can be used for detection of these genes, resistance genes. Now, what happens when? So in the lab, so what happens when we get any organism of Enterobacteriaceae family or nil fermenter, which is carbapenemase producing, then simultaneously, as and when we get resistance to imipenem, meropenem, simultaneously we start checking that isolate for other antibiotics which can be used in patients who are resistant to these carbapenem, and these include a new beta-lactamase inhibitor combination like ceftazidime avibactam, which is available in India now. So we are doing this very soon. In this month only, probably we'll be doing this second one also. Meropenem, bibarbactam will also be doing very soon in this month itself. Although it's not available commercially in India, but soon will be being launched. Then we have imipenem celestin, relebactam. So we should test for these antibiotics. Then ceftazidime tazobactam, it is specially effective for Pseudomonas. So if the isolated Pseudomonas, we should check for this antibiotic. Then we also check for Tigecycline. So there's a new one available which is better than Tigecycline called as avibactam, not yet available, but yes, it will be available soon. It is considered better than Tigecycline because it achieve MIC, which is equivalent to Tigecycline at a much lower dose. Then we have others we should normally check for colistin or polymyxin. As we know that whatever sensitivity get for colistin, it can be extrapolated for polymyxin B as well. So there is no separate testing available for check for polymyxin. Whatever we are doing for colistin, that same can be extrapolated to polymyxin B as well. Now here I want to spend 1 minute. So now because colistin we are using as a reserve drug, so normally now CSLI has recommended that we should not report any isolate sensitive to colistin. If you have seen our report, sensitivity report of late, we are reporting colistin only as intermediate or as resistant. We are not reporting any colistin as sensitive because it is proposed that colistin should not be used as a monotherapy because of the resistance, which I'll be discussing later. So monotherapy should not be, that is why we are not reporting any colistin isolate as sensitive. We are reporting as an intermediate or resistant, or we are not reporting it at all, and we are reporting it on request. Then we should look for other monobactam like astronam. And if the isolate is from urine, we should check for phosphomycin. And then also we test for MBL producer, we should specially check for combination like ceftazidime, avibactam, and astronam. So that is what we do normally. So we detect for them at least 4 or 5. We are putting them regularly. More will be putting them in this month. We are going to start few more new things that you'll get very, very soon. Now treatment. Now once we get it, we give you a report. Now here is a fix, here is a catch. Now how to treat. So now optimum treatment is uncertain. There are no strict guidelines. There are not enough randomized controlled trial. Most of them are based on observational studies. So there's a very sketchy and hazy thing about the treatment, but still I'll try to make it as simplified as possible. So basically treatment, I'll be discussing upon whether the strain is producing serine carbapenemase or oxa carbapenemase. Based on the particular carbapenemase, whether it is a serine or oxa, we will divide the treatment. We will discuss about the common regime, and then we'll discuss about the alternate regime if the common regime cannot be used. So first coming to infections which are caused by organism which belong to the serine carbapenemase, that means class A. Okay, class A carbapenemase. For them, the first line of treatment has to be ceftazidime avibactam. So we should not be giving, if the infection is mild to moderate and not severe, we should not be given a combination therapy. Patient should be getting a monotherapy with ceftazidime avibactam. And so if it is not available, then other BL-BLI combination which are not yet available in India like meropenem, bibarbactam, imipenem celestin, relebactam can be used, or a new siderophore derivative called as cefiderocol. It can be used. It is not yet available, but it will be a very potent weapon in near future, 100% sure. So now the catch here is that if the MIC, it can be used alone if it is if the infection is not so severe and patient is not severely sick. But the problem is that we have to look at the MIC. Now if the isolate is sensitive, but the MIC is elevated and it is near to the break point. Okay, if it is near to the break point, like we give the MIC, that in our report normally we take it as 21 zone diameter. So still we have not got the strip, or we have not got the MIC value, but we give a zone diameter. So if it is coming as intermediate, it is near to the break point, then we have to add a second agent. So monotherapy with ceftazidime avibactam if the infection is not serious. Combination therapy is advocated when the MIC is elevated and it is near to the break point. And it is now it is very, very important to know all the beta-lactam and beta-lactam inhibitor which are being used. they should always be given in the infusion therapy. Very, very important, because we know that for all the beta-lactams, that their killing property is decided by the time over MIC. That means the time duration above. So there, when they maintain their MIC, for a specific time, that is very, very critical in all the beta-lactam antibiotic. And as you can see that all imipenem, meropenem, ceftazidime, avibactam, they should all be given. This is the last stage column is infusion. Hours of infusion. This is the dose. This is the frequency, and this is the dose, and this is based on creatinine clearance. So based on creatinine clearance, we should be using a dose, and this is a very, very important thing, because what we have observed in various setups, that they start these drugs, meropenem, imipenem, and ceftazidime, without looking at this parameter, that what should be the dosing schedule and how many hours of infusion are required. That is very, very important, because otherwise now we are getting another problem, that most of the isolate in our setup also around 50% are becoming resistant to ceftazidime, avibactam as well. So we have to be very, very careful when we are using these antibiotic. So this creatinine clearance has to be kept in mind, and the infusion has to be kept in mind. So although there are no strict guidelines which say that infusion will definitely superior, but there are multiple studies saying that giving infusion is no way inferior than giving at a single time. And that is why we always use this in infusion. Continuous infusion or intermittent infusion, both are okay. So normally we give intermittent infusion, because continuous infusion is basically because of drug interaction, we have to give other drugs also. That is why intermittent infusion, some are, so that we have a time these kind of antimicrobial agents. So now, as I've discussed, that it is being said now that if the MIC of these BLA combination is near to the breakpoint, in that case it is always advisable. It is, sorry, in this slide something else I'm displaying. I'm saying that we should not choose polymyxins over this BLA combination. They're always superior to polymyxin. So polymyxin should not be a first choice of treatment. Polymyxin should not be a first choice of treatment if we are encountering CREs. In this study, as you can see that, so that in this study it is said that as compared to colistin, this ceftazidime avibactam, it is better to treat because of the better safety profile and greater more reliable dosing, because dosing is a very big problem in case of colistin. Adjustment is required, so it is considered superior to polymyxin if used as a monotherapy. So if the infection is non-serious. Now, as I've already told you, that now because of the use of the ceftazidime in not the desired dose and not in the desired format, we are getting resistance to ceftazidime, and a lot of strains now are developing resistance to this ceftazidime avibactam as well. And especially it's a plasmid resistance, it's a plasmid bond resistance. So that means it is going to spread very fast, and right now it is seen in KPC, that is serine beta-lactamase, and it will spread very, very fast now. Okay. Now, as we have discussed, that if the MIC of these drugs is near to the break point, then we have to add a second drug, and the second drug has to be carbapenem. So even if carbapenem is resistant, still we have to add carbapenem. As you can see here, so in vitro interaction of ceftazidime avibactam in combination with different antimicrobial agent, that is KPC producing clepsydrin pneumoniae in clinical care. So what they have studied, that combination of ceftazidime avibactam with other drug like aminoglycoside like gentamicin or fluoroquinolones does not have any synergy. But when we combine this with meropenem, then what they do is that they reduce the MIC for meropenem and imipenem below their breakpoint. Okay, so that means they have a synergistic effect, because addition of ceftazidime avibactam, it has shown that it will reduce the MIC below the breakpoint if we use them in combination therapy. So even if it is resistant, still it can be used. Now there is new drug, as I have told you, this can also be used as a monotherapy, cefiderocol. So it's a sidro-4 cephalosporin, and this is a one kind of now it is going to be a very useful drug, because it is effective against all kind of isolate, even beta-lactamase, serine, carbapenemase, and even metallo-beta-lactamase. It is effective against all kind of beta-lactamases. So it is going to be, although in India people are getting it from outside, there are few agencies in India which can import it as a special drug. It can be imported now. License is there. Okay, now as you can see that, so in vitro activity of this new drug cefiderocol that is the Siderophore cephalosporin against recently collected clinically resistant carbapenem non-susceptible gram-negative bacilli, including serine, carbapenemase, and metallo-beta-lactamase. So this study had shown that it is showing excellent efficacy against all the carbapenemase. In addition, it is also effective in those strains which are MCR1 gene producing. MCR1 is for the colistin resistance. So this drug is also now effective against the, along with the resistance against all the carbapenemase producing Enterobacteriaceae, it is also effective against the colistin producing Enterobacteriaceae family. So it's an upcoming thing. In the next few years, this will be now overused, abused, and will be killed. Now next thing so we have discussed about the treatment of infections which are caused by the serine beta-lactamases. So now we come to the treatment of infections which are caused by metallo-beta-lactamase. Metallo-beta-lactamase, as we know that metallo-beta-lactamase, they confirm resistant to all beta-lactam types except two of them, aztreonam and cefiderocol. So cefiderocol, as I told you, is effective against all because mechanism is very, very different. Now this drug cefiderocol, basically what it does to the electron transport chain. So the electron transport chain, it binds to the ferric ions and then it is transported inside the periplasmic space of the bacteria, and then it inhibits the cell wall synthesis. So it is very effective. It is not inhibited by any of the enzymes. So now treatment for this metallo-beta-lactamase producing Enterobacteriaceae family include two regimes. One is aztreonam based regime. So in this aztreonam based regime, basically we use aztreonam as a primary drug, plus we add to this ceftazidime and avibactam, or we can use independently as cefiderocol. Now why we are adding ceftazidime avibactam? Because those bacteria which are predominantly metallo-beta-lactamase producer, they also produce a lot of other beta-lactamase which may confer resistance. Therefore, when we add avibactam, then avibactam will obviously bind to these other beta-lactamase and will allow the aztreonam and ceftazidime to act. That is the purpose of adding aztreonam with ceftazidime avibactam combination in treatment of multidrug resistance metallo-beta-lactamase enterobacterials. Now, if none of the regime, so if we have discussed about both, that means those Enterobacteriaceae which are either serine carbapenemase or oxacarbapenemase. So now if we cannot give any of the drug BL-BLI combination, then what is the other option now? So when novel beta-lactamase cannot be either serine or that is KPC or oxa or MBL cannot be used, then the second line of treatment is polymyxin, which can be used in the form of either colistin or polymyxin B. So now this is never used alone. So we are always using is a second active agent, and the second active agent, very, very importantly, has to be meropenem. So meropenem, even if it is resistance, because we have discussed that meropenem resistance is a MIC of more than 4, so more than 2, sorry 4. So even if the meropenem is resistance, in that case also, if it is still till 8, we can still combine. So we have to look for the MIC when we get a report. If the MIC of meropenem is resistant, but the MIC is 8 or less, still it can be used as a combination therapy along with the polymyxins, that can be colistin or polymyxin B. I'll discuss about the advantage of colistin or polymyxin B over colistin in the upcoming slide. Or what we can do, if the infection is not so serious, we can use some other drug which are effective, like Tigecycline. Tigecycline, especially, you know that it doesn't retain activity in blood or in CSF, therefore it cannot be used for bacteremia, septicemia, or meningitis. But yes, it gets concentrated in GIT and lungs. So for pneumonia, as for intra-abdominal infection, for pneumonia and intra-abdominal infection, Tigecycline can be used as an alternative regime. Okay, now what happens? So as I've told you, if the MIC of meropenem is less than 8 or 8, we can combine with polymyxin B. Now, what happens if the MIC is above 16? So now it has been observed in various studies that if the MIC of meropenem is 16 or more, then there is no additional benefit of combining meropenem with polymyxins. As you can see, mortality rate among those who receive combination therapy regime with meropenem and those who receive monotherapy were not statistically different. That means if the isolate is resistant to meropenem, but the MIC is 8 or below, we can safely go and combine polymyxin with meropenem. But the MIC of meropenem is more than 16, we are not getting an advantage of combining meropenem with polymyxin for treating these kind of infection, serine producing enterobacterials. Now there is no apart from tigecycline, there is one more available now in the same category, that is called ivaracycline. So it is more active against tigecycline, against carbapenem resistant enterobacteriaceae, and it should be considered superior to complicated intra-abdominal infection. But the problem with this new antibiotic is that it is gaining resistance very, very fast. Ivaracycline is becoming it is developing resistance faster than tigecycline. But tigecycline has many more issues, which I'll be discussing when I'll discuss about the Acinetobacter. It has some inherent issue as well. Now, although it is said that we should not use 2 or more drug when if the MIC of carbapenem is more than 16, but yes, there are few studies they are still favoring the combination therapy even if the MIC of carbapenem is very, very high. So the reason why what they are giving, that why they are still advocating the combination therapy even if the MIC against carbapenem is very, very high. So the reason given are the high mortality related with the serious ear infection, and so some evidence is being suggesting that carbapenem, that combination therapy can reduce mortality in some case report, and there is a concern of emergence of drug resistance during monotherapy. That is also a great concern. If you use polymyxins alone, then the resistance develops very, very fast during the therapy itself. During the therapy itself, you must have seen some report. In 2 reports, it is showing colistin sensitivity, and in 3rd report, you are seeing that is colistin resistant. So now, as I've shared already, that polymyxin has multiple issues. So especially with polymyxin B, on treatment resistance is very, very common, and in colistin it is even more dangerous because of the gene called as MCR1 gene, which is plasmid encoded, so which can spread very, very fast. So this now gene, MCR1 gene, which is responsible for colistin resistance, and it is encoded in plasmid, it is spreading very fast in the hospital isolates, and it is a known fact that infection with polymyxin resistant strain, it is an independent risk factor for mortality. So if the patient is having infection with the organism which is resistant to colistin, then it is considered as a independent risk factor for mortality. Now we have discussed about the how to manage drug resistance, multi-drug resistance, or carbapenem drug resistance Enterobacteriaceae family. Now let us discuss about the Acinetobacter baumannii, so which is a MDR pathogen. So now in case of MDR Acinetobacter baumannii, we have some more agents available with us, like we have minocycline. So minocycline can be used as a drug, and it can be even given intravenously, especially in the patient with ventilator-associated pneumonia. And Tigecycline, in case of Acinetobacter baumannii, Tigecycline was comparable to colistin in most of the studies. So these 2 drugs, minocycline and Tigecycline, can be used. But Tigecycline, as we have discussed already, it is more appropriate to be used for intra-abdominal infection and pulmonary infection. It cannot be used for bacteremia or meningitis. Now what about the Tigecycline? Now in pneumonia, Tigecycline can be used, but there are various studies now which are reporting that instead of the normal dose of 50 milligram every 12 hours, if you use a higher dose of 100 milligram every 12 hours, it is showing better result if you are using Tigecycline for treatment of pneumonia. So as you can see in conclusion, Tigecycline was well tolerated at higher than standard dose in cohort of critically ill patient with severe infections in VAP subgroup. The higher dose regime was associated with a better outcome than conventional administration due to gram-negative MDR bacteria. So Tigecycline, if we are using for pneumonia, instead of 50 milligram BD, we should be using a 100 milligram BD dose. But Tigecycline has many issues. It's not a simple drug. Many issues are there with the Tigecycline. So one is, as you can see, so although it can be used, but so it has various studies have shown that use of Tigecycline, because of the bacteriostatic activity, it has a lower microbial eradication rate, and therefore the patient length of stay in the hospital is increased. So increased risk of all-cause mortality compared with all other agents, especially with patients who have acquired hospital infection, and it is rapidly enters the tissue following administration. Therefore, low serum levels, hence not effective for meningitis and bacteremia. So various studies have proven this beyond doubt. As you can see in one of the paper, Tigecycline treatment experience against multidrug resistant Acinetobacter baumannii. It is a systematic review and meta-analysis. So this paper clearly shows that subgroup analysis indicate that treatment with Tigecycline was associated with high in-house mortality compared with the cohort. Tigecycline has a significantly lower microbial eradication rate, as we have discussed, and that result in an increase in the hospital stay. Okay, so in comparison with monotherapy, Tigecycline combination therapy did not affect the mortality, clinical response, or microbiological response. So that is what the drawback of Tigecycline. Now, if Tigecycline cannot be used, or we cannot use minocycline, then what are the other agents which can be used for treating Acinetobacter baumannii non-serious infection? As we have discussed already, ceftazidime. So this is a drug which can be used against all the classes of beta-lactamase. So as we have discussed, that most isolate of Acinetobacter baumannii, they possess oxatype beta-lactamase, oxatype. So therefore, they are susceptible to ceftazidime. There is one more drug called as Tigecycline, which is now being available in US. It is FDA approved US in especially few patients, especially pneumonia, but not approved in India. So it's a broad spectrum tetracycline and retained activity in vitro and vivo against carbapenem resistant Acinetobacter baumannii. So it is MICs are lower than Tigecycline. That is why it is preferred over Tigecycline, because it receives the therapeutic concentration at much lower dose as compared to Tigecycline. So other agents like novel BL-BLI combination like ceftazidime, avibactam, meropenem, vivorbactam, impenem, celestin, relebactam. So they obviously they don't have any activity against carbapenem resistance Acinetobacter baumannii. Now, if the infection is serious with the Acinetobacter like bacteremia, pneumonia, critical illness, so along with polymyxin B, polymyxin can be along polymyxin, we should add one of the agents such as carbapenem, minocycline, tigecycline, or rifampicin. These are the combination therapy which is being advocated for treatment for a critically ill patient infected with Acinetobacter baumannii infection. So, okay, now coming to the use of inhaled colistin in patient with pneumonia because of Acinetobacter baumannii. So again, there's a controversial review. So there are many of the studies, they are not advocating inhaled colistin. So this can be used as an adjunct therapy or a rescue therapy in patients who are resistant to all the drugs except colistin. So this is advocated only on all the drugs except colistin. Now here, polymyxin B is not preferred over colistin because the risk of bronchospasm or bronchoconstriction is much more with polymyxin B as compared to colistin. So here the colistin is being advocated to treat severe ventilator-associated pneumonia in patients who are resistant to all drugs except colistin. The recommended dose is 2.5 to 4.5 colistin methane sulfate twice daily. So higher dose up to 5 MIU can be given for patient with VAP. So dose is also very important. So with no offense to anybody, it has been observed in our setting that different areas of ILBS, they are using different doses of a same antibiotic. It has been observed that different areas of ILBS, they are using different doses of same antibiotic. So please, dosage is as important as choosing the antibiotic. The dosage is as important as choosing the antibiotic. Okay, this I'll discuss in the last. Now coming to drugs overview. So briefly, I'll discuss about the various drugs now. So we have discussed about the treatment modality. I can wrap up as and when you want. I can wrap up now itself. Polymyxins are there. So polymyxins, as I've discussed, that it is said that polymyxin B is preferred over colistin because of the multiple advantages. Like as in approved by various bodies like American College of Clinical Pharmacy, even the European guidelines, IDSA guidelines, all are saying that, as you can see, recommendation 5, recommendation 6, recommendation 7. So please look at recommendation 6 and 7. So recommendation 6 says that polymyxin B has to be preferred over colistin characteristic because it is easy to maintain the therapeutic level, because we know that colistin is a pro-drug and it takes at least 6 hours from colistin monosulfonate to become colistin. So that is quite a long time. So we can't, so to achieve MIC above breakpoint will take long time. So therefore, polymyxin B should always be preferred over colistin in treatment infection. Only for the UTI, urinary infection, they are preferring colistin over polymyxin B. So optimal dose is also very important here. Polymyxin being used in different dosage. So the standardized dose in this case in polymyxin B, there is no renal adjustment required. So optimal loading dose is 25,000 units per kg, followed by the 25 kg unit per kg in a BD dose. So if the infection is because of MDR, the maximum permissible dose is 3,000 units per kg, and 10,000 unit is equivalent to 1 milligram. So 10,000 unit is equivalent to 1 milligram. This should be the standard treatment modality if when we are using polymyxin B, neither more, neither less. Now, ceftazidime avibactam. So as we have discussed that avibactam is a beta-lactamase approved in combination with ceftazidime. So avibactam, which is inhibitor, it bind to the class A beta-lactamase, which include KPC, carbapenemase, even class C non-carbapenemase like beta-lactamase, and also certain oxacillin, especially OXA48. Now, OXA48 is very, very important for us because OXA48 is a major carbapenemase which is produced by the Enterobacteriaceae, family. So that means for us, this is a very good antibiotic because it is effective against class A and also class C and also class D. Obviously, it has no active against MBL. So no BLI combination is active against MBL. So now FDA approval for this drug has been given to complicated intra-abdominal infection and complicated UTI, which is given in 2015. And then also approval has been given for treating complicated hospital-acquired bacterial pneumonia or ventilator-associated bacterial pneumonia. Approval has been given in 2018. So, so as we already discussed that it is not effective against Acinetobacter baumannii. So there is no hepatic adjustment of the dose, and now the resistance is also being developed. Already I have discussed. So meropenem, avibactam is a new drug which is available now in this, in contrast to ceftazidime avibactam. So it is in this case also no hepatic adjustment is required. So it also inhibits the KPC carbapenemase, but it does not have any action against OXA48. It doesn't have any action against OXA48. So that is why it is not against as good as, because C is not being inhibited. It is not good as ceftazidime avibactam. Now Tigecycline also I have discussed. So it is not effective against Pseudomonas and Proteus species. So double dose Tigecycline is used for VAP especially. So not recommended for bacteremia already because serum concentration is not achieved. Now minocycline is again a derivative. It is effective against Acinetobacter, but it is not a good agent to treat other Enterobacteria, not agent to treat Enterobacteriaceae. It is not active against carbapenem resistant Enterobacteriaceae as Tigecycline. So it is not a drug of choice to be used for E. coli and Klebsiella. Now ivaracycline is a new drug, as I have told you. So activity in gram-negative pathogen including Acinetobacter baumannii, but not against Pseudomonas, and its mechanism is same as tetracycline, but it has some mechanism by which it can evade the resistance mechanism. So as ma'am has said to go a little fast, so this I have already told you. Cefiderocol will be a new drug now in future because it is a drug which is stable against hydrolysis against class A, that is KPC, ESBL class B, including NDM class C, AMP-C, and class D. So even class D of Enterobacteriaceae, OXA48, and also oxas of various Acinetobacter baumannii. So this will be a drug of choice in near future, which will be effective against all MDR GNBs. So these are the various recommendation approvals. So now what is the future? So gut microbiota modulation for MDR organism for decolonization is a future now. Now it is said that our gut contain around 10 to the power 13 bacteria, and these bacteria can be classified as commensal, symbiotic, and opportunistic. And normal gut bacteria, 90% of the gut microflora include two organisms, that is Firmicutes and Bacteroides are the predominant one. Now the genes which are harbored by these bacteria can be broadly, they are called a resistome. So resistome are the genes which are harbored by the bacteria which are present in the gut. There are two kinds of resistomes. One is called resistant resistome, so which is carried normally by the commensal bacteria, which does not impart or resistance to a lot of antibiotic. And second category is called transitory resistome. So this is basically dangerous because this is basically include all the MDR genes which are transitory in nature, but over a period of time, what is the problem with them? Because they can transfer their genes to the commensal bacteria, or the transitory resistome can become a permanent resistome of the gut. That is a problem. So it is already said in many of the studies. In one of the studies, it is said that the patient who is getting Klebsiella pneumoniae, in going to the ICU, it has been said that of the patient who are having prior hospitalization, so they are carrying MDR Klebsiella much more commonly than those which are coming from the community. So this clearly studies that the patients who are harboring the MDR organism carrying the carbapenem gene, they are more prone to get affected by their own flora in near future. That is clearly been demonstrated. So what they are saying that a patient who is having a prior hospitalization So as a part of antimicrobial stewardship, so first patient in dysbiotic state, when the resistant genes are there, we should do the FMT from a healthy donor so that the gut microbiota is replaced. That is one of the strategies. So previous modality for reduction of strategy for AMR resistance. So they were saying that we should check for these things, resistance. But now they are saying that if possible, you do the FMT. So they are to the hospital with rectal swab. If they are carrying the resistance gene, then you should go for the FMT in these patients. Now, next other strategy which has been used for treatment of this CRE patient is something called as nanoparticles. So nanoparticles are the inert particle which by themselves are not antibiotics, but they have their antimicrobial activity because they can kill the bacteria. They have a direct they can directly attack the cell wall. They can prevent the biofilm formation. They can generate reactive oxygen substrate, or they can induce the intracellular killing. So of the various available nanoparticle, most effective is a gold nanoparticle. Gold, copper, silver, iron, zinc, all the nanoparticles. The most effective nanoparticle which is being further explored is basically gold nanoparticle. Then we have something called as antibiotic, combining different drug of different groups together, which may not be synergistic, but still we are trying to combine them. Now here is the data, our data. So here we are detecting various genes. So we are detecting these genes, CTXM, VIM. Okay, now look carefully. So number of tests done in September till May, around 555, 313. In 13 patients, critical stage, because here we should not, in this group of patients, we should not directly jump to carbapenem, because in this group of patients, carbapenem is not warranted at all. So once the biopsy report is negative, no organism dissected, we should de-escalate. We should do de-escalation at least in this group of patients with immediate effect, if the patient is not in a septic shock stage. Now, so in 242 we detected some organism. Out of these, 114 were polymicrobial. The polymicrobial is probably because of the improper collection, and probably it's a colonization, not a true infection. So true infection is was found in only 128 patients out of 555. So that means de-escalation thing is very, very important. Once we get a report of biopsy, we have to de-escalate on priority. So in monomicrobial isolate, still in some of them there were no resistant genes detected. In 96, that means you can see that out of 555 isolate, at the time of sending the sample immediately on admission to ICU, only 96 isolate, they were having some kind of these MDR genes, and most important gene was CTXM, and CTXM is not a carbapenemase. CTX is not it's a beta-lactamase, and then followed by the metallo-beta-lactamase like NDM, and then OXA48, which is common in Enterobacteriaceae. So that is what we are doing. So in E. coli, we can see that most common is CTXM. So these strains will be inhibited by carbapenem easily. This IMP and VIM, they are majorly present in Acinetobacter and Pseudomonas. We don't expect them to occur. OXA48 is one of the carbapenemase present in Enterobacteriaceae. NDM is also very common in India. So that is what. So we have to see the report, and then we have to take a call on what drug has to be used. So de-escalation is a very, very important. So root of these rise in antimicrobial resistance is basically lack of antibiotic stewardship. So inappropriate antibiotic empiric coverage, and delay in accurate diagnosis, and finally the delay in de-escalation. This is the most important point. Delay in de-escalation. So we should immediately de-escalate. Once we start empiric therapy, we get a sensitivity report. We look at the MIC, we look at the gene expert report. Depending on that, we should de-escalate the antibiotic. Thank you so much.